my name's Dr. Dawn Richards and I'm the Medical Affairs Director at Vitality Health. I look after the areas that deal with medical policy and complex claims. Thank you for joining us today for this episode of Clinically Speaking, which is our advisor series, whereby we discuss current topical clinical matters. Today, I am glad to say we are joined by Professor Gordon Wishart, who's a leading cancer expert. Professor Gordon Wishart has a long and distinguished career in working in cancer treatment. He is the founder, CEO and Chief Medical Officer of Check for Cancer, which is a leading early diagnosis and cancer screening service. And we are very pleased that he's here today to talk about cancer screening. I think we've all become aware that access to cancer screening has been limited during the recent pandemic, and I think what we want to understand from Gordon is more about the impact this may have in the longer term. So, Gordon, what is the current sentiment on cancer screening and hospital treatments in the UK?
So if we start with cancer screening, Dawn, we know that at the start of lockdown, cancer screening was formally suspended in Wales, Northern Ireland and Scotland, and paused in England. Now, during that time, no invitations were sent out, and more than that, for instance, someone who had an abnormal bowel cancer screening test just before lockdown didn't have any of the further investigations. Now, we know that probably somewhere close to 3 million people missed out on cancer screening from the NHS during lockdown. And just last week, Cancer Research UK posted on their news that although cancer screening services were beginning to restart, there may well be a delay in some people receiving their appointment. And they did say that for people that were expecting an appointment in 2020, it may not be until 2021. So I think there is still some uncertainty about whether they're going to try and tackle the backlog first and then move on to those that should be being screened from now onwards, or whether they're going to try and cope with, all of those people at once.
Gosh, that's a huge demand, isn't it? That will be, as you say, very difficult to deal with, a very complex situation as we've got the new patients as well coming in, haven't we? So we've not only got the old, we've got the new that aren't having screening too. Thank you. How has early screenings impacted on cancer development and patient survival rates?
I think the principle of screening, is now well established. That being that if someone has a cancer picked up by screening before they develop symptoms, then they're likely to present with a less advanced cancer, they're likely to require less treatment, and they're likely to have a better survival. So all of those are very positive things. The first breast screening program was introduced in 1986, which was the breast screening program. And more than just introducing screening, that was the first program that really brought together breast surgeons, breast radiologists, nurses, geneticists, pathologists, into what we now know are called multidisciplinary teams. And really, I think, as well as giving us some screen-detected cancers that improve the overall survival of breast cancer, it really started to say that cancer was now treated by specialist teams, and that in itself led to the kind of waiting time targets, trying to see people within 2 weeks. So I think screening did much more than just introduce screen-detected cancers. It was the start of multidisciplinary teams and the start of MDT meetings, where those patients who were diagnosed had their treatment discussed by a group of specialists rather than having their treatment decided by one individual.
What is the impact of cancer screening on breast, bowel and cervical cancer in particular?
So if we start with breast cancer, we've discussed really how it kick-started the whole screening program and MDTs and so on. But actually, what all the published data shows that breast screening will reduce the number of deaths from breast cancer by about 20%. So it has, during the last 30 years, played a significant role in helping us improve the overall cancer survival, because something like 20% of all the cancers diagnosed now are screen-detected breast cancers. So it's really the cornerstone, I would say, of the whole NHS screening programme. So it really has helped a lot of women have less treatment and have better outcome. If we move on to bowel cancer screening, then that's really just been introduced, I suppose, in the last decade. You know, that's an at-home test, so much easier for people to use if they choose to have screening. Unfortunately, the acceptance rate for bowel cancer screening is lower than for breast screening. It's about 50% uptake for bowel screening and about 70% for breast screening. So there's still a bit of a taboo about people doing an at-home test to see if they have blood in their bowel motion. But there's no doubt that it is effective and will reduce the number of deaths by about 16%. So in a tumour like bowel cancer, which tends to present late because people only realise something's wrong when they develop symptoms, bowel cancer screening can have a really important impact. If we look at cervical cancer screening, then it's different again. And there's really been a major shift in the last few years in the way that cervical screening has been done. Traditionally, women would have a cervical smear, and then if any abnormal cells were found, we would do a test for HPV, the human papillomavirus. We've now flipped that round, and both NHS and private screening now tests for HPV as the initial step in the screening programme. That's very effective. We know that it can be done at home safely, and I know that NHS England are now considering a pilot study to look at-home testing next year for as part of the NHS screening programme. It's certainly effective. We know from published studies that doing a test yourself at home is just as effective as having an HPV test by a clinician. And we've certainly got several years' experience, you know, at Check for Cancer with doing that, and it is very effective. But more than that, it's very well received by women. I think there's one more thing to say about cervical screening. A lot of people think that having a vaccine when you're young protects you completely from getting cervical cancer, but that's not the case. The vaccine only prevents about 70% of the HPV subtypes. So having an effective screening programme as well as vaccination is the best way to try to reduce the number of cervical cases. And actually, it is possible, if you do both, to eradicate that particular cancer.
It's very interesting. I mean, given the experience during the lockdown and people getting more familiar with having to cope with things from home, one can only hope that home testing in terms of the HPV and the bowel cancer screening will become more acceptable, because it's maybe become more of a norm now to take more control of your own health, and one can only hope. I think time will tell on that one. Very useful insights there. What do you think needs to happen for people to feel comfortable for hospital diagnosis and treatments?
Yes, I think it's a difficult one, and I'm not saying there's an easy solution to this, because after 6 months of really being encouraged to stay at home to work, to socially distance, I think there's no doubt that people are scared of going to their GP, and they are scared of going to hospital. But I think they should be reassured that, with effective hygiene measures in place, with social distancing, with wearing of masks, it is safe to go and see your GP if you need to, and it is safe to go to hospital. I think we are seeing cases begin to rise again in the UK, but it's a very different pandemic from what it was like in April. The number of deaths is still quite low, and I think as far as cancer is concerned, people are more at risk of leaving a cancer undiagnosed and untreated than they are of developing symptoms from COVID or something more serious from that infection. So I would really encourage people to go and get checked, not to sit at home on any symptoms, and to accept cancer screening. Because if we don't get effective cancer screening and diagnosis up and running again, then we'll have far more deaths from cancer than from coronavirus.
Yes, it's an important message. I think us as clinicians have to repeatedly get out there, isn't it, and reiterate that it is safe to come forwards for treatment, really, isn't it, and diagnosis. Thank you very much for sharing all those insights with us today. They were very helpful, and I certainly found them useful. As you know, Vitality do allow our members a discounted access to cancer screening services provided by Check for Cancer. That's for cervical cancer screening and for bowel cancer screening. Our members also have access at a discounted rate services to predict your risk of developing breast cancer, a lifetime one-off risk assessment, which again is provided by Check for Cancer. Thank you once again, Gordon, for coming and talking to us today, and thank you to you, the advisors, for taking the time out to come and listen to us and watch us today. Again, I am Dr. Dawn Richards, the Medical Affairs Director at Vitality, and you've been watching this episode of Clinically Speaking. Please join us again for the next episode in October. Thank you. Goodbye.